Good morning. The Wellness Committee is excited to present today's program on the important subject of sleep. I must say that in talking to people about this program, I came to realize how many of us have sleep issues. I'm very happy to introduce Dr. Martin Hsia today, who'll be discussing the elements of sleep, why sleep is important, what happens when we don't get enough sleep, and how to protect against or address insomnia. Dr. Hsia is a well-known psychologist, behavioral health consultant, and sleep expert. He practices in Glendale as the clinical director of the Cognitive Behavior Therapy Center of Southern California, and is a colleague and friend of our own Dr. Jeff Prater. After Dr. Hsia's talk, please feel free to take copies of Dr. Hsia's literature on the tables, as well as information there from Monte Vista Grove Homes regarding their great wellness programs. So without further ado, let's welcome Dr. Hsia, and thank you so much for speaking to us today.
I think he wants the mic on the stand. Yeah. Oh, thank you, Barbara. Everyone hear me okay back there? Okay, great. My voice projects, but I can't hear how I sound over there, but this is working okay? Okay, great. A pleasure to be here this morning, St. Patrick's Day. It's very big in the Chinese community. That's a joke. So I'm a psychologist. I work with a group of therapists called CBT-I, the Cognitive Behavior Therapy Center of Southern California. As Barbara said, we do a lot of things. We're talk therapists. We specialize in helping people with insomnia is one of the things we're known for the most, but also helping people with all types of anxiety, phobias, panic, social anxiety, and most specifically OCD, but a range of other things from there. I'm going to make the case today as for why insomnia is actually, you can think of it as an anxiety disorder focused on sleep. And we'll get to all that because that's sort of what we know the most about sleep. Just to kind of start getting us thinking autobiographically on this topic a little bit, how many of us have ever had trouble falling asleep? Everyone's just laughing, right? How many of us have ever had trouble staying asleep? Right, okay. These are the low-hanging fruit questions here, right? How many of us have ever worried about what would happen or what would happen the next day if we had someplace important to be or something important to do, that if we didn't get enough sleep the night before, that would somehow affect us? Yeah, of course, everyone. And how many of us can recall what it feels like to be awake after a night of insufficient sleep? Right? All the people in the back are like, what? Can you repeat that question? Yeah. So again, we can all relate to this at some level. It's a very common thing. And we all know that sleep is important for our health, vital for survival. And yet it's this weird thing, because if you hear sort of health and wellness coaches, you hear a lot of talk about what we eat, how much we eat. There's all sorts of diet plans under the sun, wellness plans, exercise plans, bar method, this method, that's great, all sorts of different. I'm all for that. Diet, exercise, and then it's sort of like, and make sure you're sleeping enough. And it's sort of like it's implied, but in some ways, the importance of sleep kind of, I feel like, takes a back seat to diet and exercise. And if one thing I hope we'll get out of this today is to see that it's really, it should be an equal pillar of supporting our health and mental health. Sleep is a weird thing if you think about it, right? Because we all know it's important, right? And yet it's kind of inaccessible, right? And until really recently, when we've sort of developed more complex scientific tools to study the brain and all these sorts of things, and sleep studies and dream studies, you can't ask someone what's going on while they're asleep because they're asleep, right? And so compared to lots of other areas of health, our knowledge about what happens when we're sleeping has sort of been a little bit delayed, if you will, but we're getting there. Another thing to think about is from an evolutionary standpoint, if you think about it. If we generally all agree and understand that sleep is so vital and so important, at the same time, if you think about, millions of years ago, if we were cave men and women having this conversation, when you're asleep, doing this very important thing, you can't actually do any of the other things that are important for survival, right? You can't hunt, you can't gather, you can't socialize, you can't mate, you can't even really protect yourself if a saber-toothed tiger comes into your cave, right? So that seems like it doesn't make much sense. It's very contradictory, and yet it's such an important thing. I will say, I call this, it's the essence of sleep, the absence of sleep, and its defense. Because I just, again, we all know it's important, but I'm going to talk just a little bit more about sort of why, some statistics and some information as to the mechanics of sleep, kind of what happens when we don't sleep enough. And then I'll talk specifically about insomnia. As I said, there's a number of different types of ways that sleep can be a problem, or ways that we can develop sleep disorders. Insomnia is the most common, and that's the one that we have the most specialty treating in our practice, if you will. And at the very least, if what I accomplish here today is that some of us, catch a couple extra Z's in here, that's fine as well. Whatever you folks need. Some folks already gave me the heads up that might happen, and that's fine. I won't take it personally. So let's talk about the essence of sleep. Yeah, there's one thing I found throughout my career in every place that I've worked: community mental health settings, across ethnicity, socioeconomic status. I worked with veterans with PTSD, people in nursing homes, palliative care, chronic pain, now with OCD and anxiety. I used to work with Jeff Prater closely here in South Pass, kids and teens with ADHD. If there's one thing that's been universal across every setting and every population, is if you help someone sleep better, everything gets better. And that shouldn't be a secret, but it's just really, really been the case. And there's a number of ways in which specific functions that sleep supports for us, right? So it's not a secret, right? We all know we're getting a little more cranky, we're a little bit more prone to get stressed or worried or anxious, emotion regulation if we're not well slept. We have less energy, we know that, right? Memory consolidation is actually really interesting. There was a study done where they took a group of young adults and they gave them a simple task of like remembering pairs of names with faces, right? And then they took half the group and said, okay, you get to take a little 90-minute siesta in the afternoon, and the other group was not allowed to take that nap. And then in the early evening, they tested them again, and lo and behold, the group that was able to take the little nap performed 20% better on the recall. Okay, so there's something that happens when we are asleep that helps consolidate information, learning, and memory. Okay, and it's actually quite fascinating because some of us may know different aspects about the physiology of the brain. There's a part of the brain called the hippocampus, and that's where our short-term memories are sort of triaged, and they're sort of hanging there in temporary housing, if you will. And then what happens is when we sleep in non-REM deep sleep, which is one of the stages of sleep, the information and memories and experiences that we've had gets moved into the cortices, the cortex of the brain, which is more permanent housing. It's a more secure hard drive, if you will, right? So literally, sleep is changing the architecture of our brain and helping us consolidate what we learn. Cognitive performance, so for any of us who are or have been or know musicians, athletes, right? The whole practice makes perfect. And you found that if you've ever tried to speak a language or learn an instrument, that you play something over and over, and 3, 4, 5 times it gets better. And that happens in a waking state. However, what we also find is that similarly, the sleep in between and then coming back to practice is what really gels that learning. The coordination of muscle memory. The memory is not actually in the muscle, the memory is up here, right? And for athletes, it's well proven by research that sleep supports strength, stamina, response time, temperature control, metabolism, pretty much everything that it would take to be a successful athlete and perform at our best level, right? Immune system function, right? For those who are underslept, we're more susceptible to cancer, cardiovascular disease. Sleep helps regulate our metabolism, our blood pressure, all very vital things that support our health, right? I'm not going to go too much into this, but we've heard about some of us may know more about this than others, but the sort of stages of sleep. We're awake, then we go into stage 1 and 2, which is similar to a waking state. It's sort of not that deep. And then about 45 minutes later, we go into deep sleep, which is really, that's like if we were awoken during deep sleep, we'd be the most disoriented, if you will. And then we kind of cycle back into what we call REM, rapid eye movement, which we associate with dreaming, very vivid dreams. And then we cycle back in, 1, 2, 3, 4, REM, 1, 2, 3, 4, back up to REM. And I want to hit on this because REM is such a fascinating and important aspect of sleep that we need to preserve and protect. And all creatures sleep, by the way. Even it's been shown that plants have circadian rhythms where they kind of wilt naturally, even if you deprive them of sunlight, and then they perk up in anticipation. Invertebrates, reptiles, amphibians, insects, worms, all sleep. I don't know if we knew that, right? It's pretty interesting to think a little worm out there. But, however, only birds and mammals produce REM sleep, which suggests, right, that REM is an evolutionarily very advanced thing. If we are sort of the top of the food chain with all the things that we can do cognitively, problem solving, create, evolutionarily, REM is one of the things that helps produce and sustain that aspect of our functioning. Another interesting thing that supports that is other primates that produce REM, about 9% of their total sleep is REM sleep. The rest is other stages, non-REM sleep. For human beings, for us middle-aged and older adults, about 20% of our sleep is REM sleep. We produce the most. Fetuses in the womb are pretty much 100% in REM sleep. Once they're newborn, they wake up, they're cute, and then they poop, and you change the diaper, they go right back to sleep. They're pretty much right back into REM, okay? And that slowly, the proportion starts to decrease over the first year of time and progressively through childhood, teen years, to the point where middle-aged and older adults, like I said, about a fifth of our sleep is REM. The rest is non-REM, which again is also sort of like REM sleep. That aspect or that stage of sleep is so vital for brain maturation and the development and growth of neural pathways, especially for our young ones, yeah? Another really fascinating thing. REM sleep, specifically, when we suppress it artificially or not artificially, our ability to read social cues and facial expressions diminishes. So what does that tell us? We're social creatures. We're made to be in community. And our ability to do that in the most nuanced and complex ways and connect with another individual and express and feel empathy is impaired when we have inadequate REM, right? So it's, long story short, it's very important that we do that. Does anybody know the best way to suppress REM? Well, to not sleep enough is one way, right? Is to abuse alcohol. Alcohol is the most powerful artificial, if you will, suppressor of REM sleep. And by the way, anyway, does everybody know, like, among the sort of animal kingdom, if you will, like who sleeps the most, who sleeps the least? Brown bats are awake for about only 4 or 5 hours of the day. So anytime you see a brown bat around San Marino, that's a quite rare thing. I don't know if there's brown bats in San Marino. And elephants are actually, they only sleep for about 4 or 5 hours of the day. They're pretty active animals, yeah? This is sort of, like I said, the sleep cycle is what it kind of looks like. We're awake, we come down into sleep 1 or 2, 1 and 2, and then we go down to 3 or 4, delta, slow wave, or deep non-REM sleep 3 and 4. And then we come back up, we have some REM, and then we cycle back. What do you notice about this standard cycle, though? That's right. The proportion of REM increases through the course of the night, right? So on the back end of this, 8-hour sleep period is where we're getting the most REM, our most important, if you will, evolutionarily advanced aspect of sleep. So this is why, one of the reasons why the World Health Organization and the National Sleep Foundation recommend 8 hours of sleep, or at least a minimum of 7 hours of sleep, right? Because that's where we're getting the most important thing. Now, let's talk, or I'm going to segue straight from there into the absence of sleep and why that's a problem. Does anyone want to take a guess? Among developed nations, what percentage of people obtain on average that recommended 8 hours of sleep? Is it 100%? No, right? Not 0%. Somebody's getting it. 20%? It's about a third. It's about a third of people in developed nations get that recommended 8 hours of sleep on average. Okay, and so interestingly there is, of the nations where statistically on average sleep has decreased the most over the last century, rates of health and mental health issues have increased the most. Correlation, causation, And of those nations, United Kingdom, Japan, South Korea, and us right here, the United States. Okay. So it's an epidemic. If we are averaging 6 hours of sleep or less, compared to someone who is averaging 7 hours or more of sleep, our rate of cancer doubles. Our likelihood of having a heart attack or stroke increases by 200%. If we're trying to lose weight, the best way to do that is to sleep less so we have more time to be active and exercise, right? No, right? Obviously. But I'm going to explain, there's sort of like a triple whammy as to why that is really not the case, okay? Because when we are underslept, a number of things are going on. We wake up, we haven't had enough sleep. Ghrelin, which is a hormone that tells us to feel hungry, is increased. We have higher levels of ghrelin. And at the same time, we have a suppression of the levels of leptin, which is the hormone that tells us that we're full. So our body is literally telling us we need to eat more. We want to eat, and we want to eat more before we can feel full if we're not well slept. So that's one problem. Secondly, the part of the brain that is most impaired when we're underslept is the prefrontal cortex, which is one of the most advanced parts of our brain. That's where we do our novel problem solving, our complex critical thinking, judgment, and inhibition, right? So again, if I'm underslept, it's going to be a little bit harder for me to choose the Doritos to not choose the Doritos over the carrot sticks, right? My judgment is not going to be as good. It's going to be harder for me to resolve those kinds of conflicts and make good decisions while I'm already feeling more likely I want to eat more. Yeah. Third triple whammy as to why, if I'm trying to lose weight, being underslept is going to be a big problem. Is when we're underslept, we have an increased activity in the endocannabinoid system. Anybody know what endocannabinoids are? Endocannabinoid, cannabis, the receptors that respond to cannabis, aka marijuana. And what do we associate with marijuana? Hunger, the munchies, right? So there's a number of things going on, different systems and hormones that are stimulating hunger, decreasing the feeling of being full, and just we're not making our best decisions. So if weight is something that we're keeping an eye on, sleep is going to help with. This is where the interplay between sleep and diet really come together. Matthew Walker, who's a researcher up at UC Berkeley, he goes so far as to say that being awake, us right now in a waking state, we're basically doing low-level brain damage to ourselves. and that when we sleep, it's sort of neurological sanitation. All the bad stuff is getting cleaned out. That might be a little bit alarmist, but you kind of can make a case for it, right? So by the numbers here, right? About 50 to 70 million Americans meet criteria for a sleep disorder. That's about 15-20% of our population. It's a lot. Of the various sleep disorders, insomnia is the most common. Others include sleep apnea. Someone was asking me about it earlier. Narcolepsy, restless leg syndrome, circadian rhythm disorder, which is sort of the clock that signals us when to get tired. That shifts over the lifetime, by the way, and some of us naturally are what we call larks. Some of us are owls, right? Larks shifted early, like to go to bed early, wake up early. Some of us just cannot get to bed at the time that we want to be able to function within the structure of our lives. Night owls, right? Go to bed later, wake up later. And sometimes that can be very disruptive for someone's lifestyle, right? And the last is, nightmare disorder, right? Which is sort of a newer, everyone knows about nightmares, but that wasn't sort of given its own proper label, if you will. But it's its own disorder now, and there are ways that we can treat that, if you will. And somnambulism, or what we call parasomnia. So that's doing all sorts of interesting things in our sleep, walking, talking, texting, fornicating. And in very rare, usually parasomnias are pretty benign and not problematic. In very, very rare cases, someone committed a homicide in their sleep. This is 1987 in Toronto. A man woke up and said, "Why is there blood all over me?" And he apparently had murdered his mother-in-law. So, but that's very, very rare. Drowsy driving. So this is an amazing statistic. This always stands out to me. Is motor vehicle accidents that are related to fatigue and drowsiness outnumber motor vehicle accidents that are related to drugs and alcohol combined. Never would have guessed that, right? That's not to say there are more deaths caused by drugs and alcohol and driving. But accidents altogether, and even if which no one sustains major injury, more caused by fatigue and drowsiness. That's shocking, right? So let's talk about insomnia specifically. Again, because it's the most common sleep disorder, and because that's the one I happen to know the most about, and that may interplay into some others as well. That's why I sort of alluded to this earlier. Is insomnia is not just difficulty sleeping. It could be difficulty initiating sleep, or it could be difficulty maintaining sleep, right? So some folks, it's like, once I'm out, I'm out. I just have trouble, like I get in bed and then I'm lying awake for half an hour before I fall asleep. Other people, no, I hit the pillow, I'm out pretty well. It's just in the middle of the night, I wake up for various reasons, and that's when I have trouble getting back to sleep. It obviously impairs our daytime functioning. Sometimes we call insomnia, it's not just a sleep disorder, it's a sleep-wake disorder. It's really 24/7 because it's not just our sleep is impaired, it affects our daily functioning, all the things we talked about earlier, versus if you compare to maybe some of the parasomnias, which really just impair sleep or affect our sleep. Real important point to make is that insomnia is not the same as sleep deprivation, right? So people can be sleep deprived because they're not giving themselves adequate opportunity to sleep. Some people are just super busy. I work myself to the bone. I stay up too late. I wake up too early just cause or whatever. It's not that they can't generate enough sleep. They just have not given themselves enough opportunity to sleep. That's sleep deprivation. That's more by choice. With insomnia, people are giving themselves enough opportunity to sleep. They're just not able to generate as much sleep as they like or need. Sometimes people are giving themselves too much opportunity to sleep, which we'll talk about, and that's a major problem. And in fact, the tendency with insomnia is to spend more time in bed, either to say, well, I'm having trouble sleeping, so if I get in bed earlier, I'll give myself more of a chance to fall asleep earlier or get in bed. And if I'm awake in the middle of the night, well, I might as well stay in bed because maybe I'll fall asleep, and then I woke up in the morning, and then, well, if I stay in bed, maybe it'll be kind of like I'm resting, and that's counterproductive. I'll say a little bit more why in case it's not already intuitive. Also, by the way, again, this speaks to the piece of insomnia really being about anxiety. And again, some of us can relate to this. Probably, maybe all of us at some level. Where we get in bed, trying to fall asleep, and sometimes, or maybe often for some of us, we have trouble initiating sleep. We might get anxious, we might get worried, we might get frustrated, toss and turn, I can find another position, side, this side, hand up here, back, right? Stuff a pillow under my legs. I do all those things, by the way. But it's the worrying that's actually the problem, right? Because what are we doing then? We're basically building up cortisone, adrenaline, stress hormones, and starting to associate that with a time and place and context in which we're wanting to relax and to be able to sleep. It's inherently not compatible, right? I won't go into detail here, but regarding psychiatric medications, mental health issues, mental health treatment, there's many reasons why insomnia is a problem. There's this sort of old line of thinking, which is that insomnia and sleep issues are pretty much kind of like a side symptom of a other primary issue or mental health issue, say depression. Depression affects our sleep. And so the old thinking is if you treat the depression, if you help someone improve their mood, then the sleep will improve, insomnia will go away. And in many cases, that is the case. And in a lot of cases, as research and clinical lore and wisdom is really coming to its senses, is that's not always the case. And a lot of times you help someone improve their mood, you treat the depression, but they still have insomnia, right? And what we even find in other cases is actually insomnia is the primary issue. And dealing with that over time and just the revolving door and cocktail of different medications and frustration or whatever, I have no sense of mastery over this thing that my 6-month-old grandson has mastered. What builds up is a feeling of frustration, hopelessness, aka depression, right? So it's bi-directional, if you will. So we've established that it's important. We've established that it's a problem if we don't get enough. None of which nobody knew, but just kind of filling in some details there. How do we defend sleep, and how do we address or prevent insomnia even better, right? And so we mentioned earlier, so our practice is called the Cognitive Behavior Therapy Center of Southern California, or CBT-SoCal. Cognitive behavior therapy for insomnia is really sort of becoming one of the well-established treatments for it. And long story short, some of us may be more familiar than others perhaps, but again, we're therapists. There's different sort of schools of thought and approaches to psychotherapy, talk therapy, mental health counseling, if you will. Sort of more traditionally in the old days is more psychoanalysis, right? You lie on the couch, come in 3, 4, 5 times a week over decades, and the emphasis is a little bit more on sort of early development with primary caregivers, parents, and how that gets sort of reenacted in the relationship with your therapist. And that's great. There's definitely a place for that on certain kinds of issues. However, CBT it lends itself to a lot of things where someone may not have the time or the resources or the patience for that. There's a lot of things where people need skills, tools, conceptualization and organization. What can I do about an issue now? I am dealing with panic episodes, OCD. I need help now. I'm in distress. I'm dealing with insomnia. I came from a great family. I don't want to be dealing with this for years. I need tools. I need skills. And CBT is really sort of lends itself to that. We're a little bit more concrete, hands-on, tangible with what we're recommending for people. And you just kind of have to do that with a lot of things like OCD and insomnia, which we specialize in. We give people things to be working on, thinking about, applying, practicing in between meetings to keep the process going a little bit more fluidly and moving faster. CBT, we work from, this is all relevant, I promise, from basically the interplay between thought, how we think, what we feel emotionally, and what we do, habits, behaviors. So just a quick example is if I have insomnia, the thought that may have built up over time for me is that I can't sleep without my lorazepam, whatever, which by the way is not technically supposed to be used chronically for sleep, but gets prescribed by a lot of primary care doctors because they want to help, and maybe don't know better, I don't know. But if that's my thought, is I am physiologically incapable of sleeping without my lorazepam or Ativan, then what happens? Oh, it's 9 o'clock. Oh, I haven't taken my Ativan yet. Get anxious. I better take my Ativan. Well, I took it. Behavior. I get chilled out, calm down. Reinforces that thought. Oh, good thing I took my Ativan. Now I can go to sleep, right? Or let's say I'm the kind of person who's at a different point where I say, you know what, I've been taking this for years. I'd rather not take it if I don't have to. I don't like the idea of being dependent, which is, by the way, very frequently when people consult us is when they've been taking an Ativan or in the old days it was Valium, right? Ambien, Lunesta, all these, so many sleep meds now, right? And they say, well, it was working for me for years, and then one day it didn't. And then people really get scared because they say, oh my gosh, this thing that was working for me now doesn't work. Now I'm really in trouble. Help, I got to find something else. And then they find out about CBT-I or CBT for insomnia. But so if I'm the person who's at a point where I'm saying, let me see what happens if I get off this medication. So tonight I'm going to not take my Ativan. And then okay, then I go to sleep and I'm like, oh my gosh, 15 minutes, 20 minutes, 25. Then I start getting worried, start getting anxious, start getting frustrated. Hey, I got to drop off my kids. I got to get to work, right? Then I get worried, and then I feel hopeless and frustrated. You know what? I better just take the Ativan, right? So behavior reinforced, and then again the thought. Oh, see, I can't sleep without my Ativan. I'm dependent on it. I need it. So that thought gets stronger and stronger over time. So CBT for insomnia. Long story short, how are we doing on time, by the way? Okay. Is basically, we're a team of psychologists, licensed clinical social workers, and marriage and family therapists. None of us are licensed to prescribe medications. We're not dealing with any pills. This is all about skills, right? So it's a non-pharmacological approach to dealing with insomnia. We use the principles of behavior change that I kind of alluded to earlier. It's skill-based and brief, right? So we've seen people, in best-case scenarios, get better in 4, 5, 6 meetings, where they feel like they're really kind of gaining a rhythm and regaining a sense of confidence that they can sleep regularly and or even on their own without medications, if that's the goal, right? The benefits of CBT-I that we do is, again, it's effective, just as effective as sleep meds, research shows. But better is that the benefits of it are shown to last longer, right? Why? There's no side effects. We're manipulating someone's sleep schedule and thinking, and we'll get to that briefly. but I'm not prescribing anything that's going to throw off anything else physiologically, right? Which is great. Most people would like that. And all the other things, benefits, other than sleep, mood, irritability, overall functioning. Sometimes the question comes up, can you be going through CBT for insomnia while taking sleep medication? And the answer is yes, provided that it's the kind of medication that is taken as prescribed, consistent dosage, and at the same time every day. What we don't want is people who are sort of taking like, oh, I'm pretty tired, I think I'm going to not take it today, but tomorrow maybe I will take a lower dosage, and I'll take it a little earlier today because I got to be. We don't want people tampering with medication sort of as needed, PRN, if you will, because that sort of skews the benefits of what we're trying to do. Brief introduction to this because it's a little bit more technical, but just to kind of give folks an idea of components of CBT-I are fourfold. Sleep hygiene, which people generally sort of have a handle on even when they find us. Cognitive restructuring, which is a fancy, unnecessarily fancy word for just dealing with people's thoughts and thoughts that may be faulty or not productive around their sleep or just inaccurate. Stimulus control, again, unnecessarily fancy behavioral term for what are we beginning to associate or what have we been associating with sleep and with the bed and with the pillow and all that, because if it's stress and all sorts of things other than sleep or relaxation, we've got to find a way to break that. And number 4 is really the meat, I find, of CBT-I, which is sleep restriction, managing people's sleep schedules to enhance sleep drive. Okay. Real quickly, sleep hygiene. Most people know most of these things, right? It has to do with diet, exercise, keeping consistent bedtime, consistent and relaxing bedtime routine. What is the environment in which we sleep? Not watching scary movies while in bed. Not eating in bed, right? Not abusing drugs and alcohol and nicotine, caffeine intake, watching that, right? There's been so much written about that fourth bullet point down, electronic devices, right? Where, because the blue light that's emitted by the LED lights in our iPads and phones and stuff that we didn't have decades ago, right? We read that in our bed. That's the last thing we do before we go to bed. Is that the light sensors in our eyes are more sensitive to the shorter wavelengths of blue lights than, say, a desk lamp or what have you, right? Now, having said that, there's actually more mixed research on that finding than a lot of people realize. Why? Because a lot of those studies, especially initially, were conducted on college students who tend not to be known for regularity and quality and quantity of sleep. But I'm not throwing that out at all because some people are very affected by that. Other people find that's not a main thing. So it's a little bit, case by case in my experience. Cognitive restructuring, again, how do we address people's inaccurate and unhelpful thoughts that they've built up around sleep, right? If I spend less time in bed, I'll sleep less, so I better stay in bed more. Again, we talked about that, not helpful. We don't want that. I absolutely should sleep at least 8 hours or XYZ bottom. If I don't, I'm at risk for Alzheimer's. Now I'm going to sound like I'm contradicting myself because I said that earlier, that 8 hours is important with the REM and the WHO and the National Sleep Foundation. However, what I just want to say sort of again as an asterisk there is a lot of people with insomnia develop a very rigid way of thinking about that if I didn't get 8 hours of sleep last night, then, right, something horrible is going to happen. I'm going to crash my car, I'm going to hit a pedestrian, I'm going to botch up my talk at San Marino Church, or, I'm going to have Alzheimer's, right? And on any given night, that may or may not be the case. And sometimes we get a little bit too extreme or catastrophic, and that feeds the insomnia, actually. It's not helpful. The third point, if I don't sleep well tonight, I won't be able to function. That's always an interesting one to debunk with a lot of people, because I always say, so you're worried that you're going to lose your job or that you're going to make a fool out of yourself, like if you haven't slept well enough. How many times has that happened? And more often than not, people say, well, it's never happened, right? But I'm just worried about it, right? Again, anxiety disorder about sleep or inadequate sleep. Some other common ones, if I slept well, I should wake up feeling refreshed. It kind of depends what stage of sleep we might wake up in. For older adults, right, if I'm older, insomnia is just normal. Now, so statistically, older adults do sleep less. However, it's not shown that older adults need less sleep, contrary to what a lot of people think. There's lots of reasons around that. Somebody mentioned earlier, right? For older adults, we might have more health problems. We might be taking medications that have side effects that disrupt our sleep to address some of those health problems. We may be dealing with pain, right? Our circadian rhythm, I mentioned earlier, shifts over time. For sort of teenagers, it shifts later. So the clock as to when they naturally want to sleep is actually shifted later. There's a lot of articles folks might have read about how it's actually really problematic that we force teenagers to get up and go to school that early. And then it kind of goes back into middle, later adulthood where the circadian rhythm shifts earlier, right? And so, for older adults, our tendency may be to, 7, 8, 9 o'clock, maybe we want to nod off because the clock is telling us to go to sleep, even though we want to go to sleep maybe later on. And so what happens a lot is if we get to that point of dozing off and we've sort of nodded off, then what happens is our sleep drive, when we actually try to go to bed, has been decreased. Yeah. So there may be a number of things going on for any of us in that stage of life, but I wanted to put that in there. I can't do anything to help myself sleep because it's a chemical imbalance, right? This is the allure of the purely medical way of thinking about things. My mother and her mother had insomnia, so I'm just that's my cruel destiny to suffer. Well, hold on now, right? Stimulus control, again, fancy term for what are we associating with the bed. I don't want, so for someone dealing with insomnia, I don't want them in bed just trying to fall asleep, right? For the most part, if we're not sleepy, I want worrying, doing things, do that somewhere else. Get in bed only when we're about to sleep for the most part, right? The worst thing, right, is I've associated with the bed now sleeping and relaxing, and at the same time, tossing and turning and worrying and getting frustrated and hopeless, right? We don't want that. We want a clean association, and that takes a while to change, by the way. If I don't fall asleep sometimes I'll tell people, after 10 minutes, you kind of know if you're going to fall asleep pretty soon or not. 20 minutes at the most, I just don't want prolonged tossing and turning, so I'll tell people, if you get in bed, if it doesn't look like you're going to fall asleep pretty soon, get up. Do something else. Go to another room, do a jigsaw puzzle, Sudoku, something not too stimulating, it's kind of boring, mindless, and then come back to it. Come back after another 10, 15 minutes. Are we sleepy? Does it look like, okay, maybe now I can go down. Good, great. Then we haven't spent that time in bed tossing and turning. If you come back and you're still having trouble falling asleep, get back up. Same thing, rinse and repeat. I just don't want that prolonged time in bed. Use your bed only for sleep and intimacy, right? And even then, if you really want to keep things interesting, then just do sleep in bed. You can do the other thing somewhere else. Just spice it up a bit, that's fine. People maybe are familiar with Pavlov's dogs, Pavlovian or classical conditioning. This was an old study, classic psychology study, which is basically we associate things that might not otherwise be associated. For example, this dog, he smelled food or the meat powder, and he naturally, I'm hungry, that smells good. He starts to salivate. And then they would start to ring a bell when they would present the food or the meat powder. And then the dog starts to associate the bell with salivating and meat powder. And then pretty soon, even when they took away the meat powder and just rang the meat powder and rang the bell, the dog starts salivating, right? So similarly we from infancy, for the most part, right? When we're lying down, we're in bed, sleep, comfy, but we can build up an association, a conditioned response, if you will, of arousal and alertness and all those stress hormones to the bed and to bedtime. And lastly, sleep restriction is, again, dealing with people's sleep schedules. So we improve people's sleep quality by consolidating sleep drive. And long story short, that means we delay the time when someone gets in bed because I want to build up adenosine, which is the hormone that initiates sleep. But at least, and this is temporary, we're going to hold the time when you wake up, right? And that's going to be painful initially, right? So typical rule of thumb, so let's say if you are someone who wants to get up at 7 a.m. every day to get ready and do what you have to need to do. And on average, and we would have people fill out a little sleep log to track how much sleep they're averaging per night over, say, a 2-week period. If you're averaging 6.5 hours of sleep, but maybe you're getting in bed at 9:30 or 10, and you're up and down and tossing and turning, whatever, that's what we call poor sleep efficiency. The ratio of time asleep to the time actually in bed, we want that to be pretty close. We don't want a big gap there, right? So if we want to get up at 7 and we're averaging 6.5, 7 minus 6.5 takes us to what? 12:30? And be generous and let's give you an extra half an hour. So that means bedtime, you get in bed at midnight. This is sleep restriction. And then so we're going to, for a temporary period, we're going to be getting in bed at midnight and you wake up at 7. And then they say, oh, wake up until midnight. Are you kidding me? I'm going to be exhausted. And then I say, well, you're already exhausted, which is why we're here talking. So why not at least do something, change something intentionally, and if we have a better benefit over it, or a benefit from it, at least we feel like we have some sense of agency and regaining a sense of control that I'm tired, but it's at least because I'm doing something on purpose and with a reasoning behind it, right? And now here's what we do is, let's say you're sleeping pretty consistently. Oh, I'm so exhausted, I can barely keep my eyes open. 12 o'clock, but 12 o'clock by the time I get in bed, you're gonna be sleepy, right? You crash, more likely to sleep through the night, wake up at 7, like, oh my God, I wanna hit snooze, but okay, then we get up. And now we're sleeping pretty consistently, 7 hours, right? That's good. Or maybe that's not happening, but if it is happening pretty consistently and it feels like we still need more sleep, then we start to slowly add increments on the front end. Okay, you've just earned yourself the ability or the stamp of approval to go to bed at 11:45 for the next 2 weeks. And if we can still pretty consistently, our sleep efficiency, 90% of our time in bed is asleep, 11:45 to 7, great. Hey, over 2 weeks, then we'll add more time. Great. So there's a number of benefits to that. It improves our sense of confidence in our ability to sleep naturally sometimes, or even with medications if we're taking them for different reasons. We're minimizing negative arousal, right? The stimulus control piece of the bed. We talked about naps earlier. We don't want to do that, right? Because what happens through the course of the day, let's say we wake up 7 a.m., adenosine, that hormone that is initiating sleep by the time it's time to go to bed, building, we go to sleep, boom, it plummets during our sleep, and then it starts to build up again the next day. But when we take a nap, what happens? Shoo, right? Oh, no, I'm a new man, right? And oh, shoot, well, it's already time for bed, and then wide awake, right? And has that ever happened to anyone here? Yeah, sure. Sometimes we say, so really the key is consolidating sleep drive. If you take one thing away, I want to think about that. Naps are fine, by the way, if for someone who's a good sleeper. It's not really a problem for you. But for someone with insomnia, it's kind of like giving a cupcake to a diabetic. We don't want to do it. So these are a couple quick clinical examples, and then we can take some questions before we wind down. So this is a sample sleep log I had someone do. This was a person in their late 60s. And so A is for alcohol. Those are the days when they had a drink. Not a lot, just a glass of wine or 2 with dinner. The black areas are when they noted they were asleep. M is when they took medications, so in the morning when they woke up. C is for caffeine, so I had coffee in the morning, usually. And the E is for exercise. This is a very active person, right? Does a great job with exercise. One time on the first week there, took a Unisom at 2:30 a.m. to get to sleep, because you could see he, 3 hours was not able to fall asleep that first night. So a couple of interesting things stand out here is, if you notice, there's irregular bedtimes, right? And that's not good sleep hygiene, as we said, so we want to address that. There's definitely inconsistency with how long it takes a person to fall asleep. There's a lot of waking up in the middle of the night, which is very, very not fun, right? And a lot of frustration. And then there's a lot of irregularity on the back end, waking up at different times, which, by the way, will kind of mess around with the timing of the sleep drive build up for the next day, right? Which is why the consistency is so important. There's also some naps, right? So this is the pre, and later on, this is what we got to. So, it's not perfect, but I would take this over that, yeah? Wouldn't you? Pretty consistent, getting to bed at a more consistent time, still able to enjoy the, little nightcap there. I'm not a prude here, right? Alcohol's okay in moderation. Keeping up the exercise, that's great. Taking medications as prescribed. There's still some nights of waking up in the middle of the night, but far diminished. Look at that. 3 hours, 4 hours, about almost half, more than half the nights here. That's 2-3 times in 2 weeks. I would take this, yeah? And pretty good about consistency waking up in the morning at the same time. Here is an art student, late 20s. Yeah, very active. Again, a lot of exercise, doing a great job there, which builds sleep drive. But boy, this is like hockey player teeth here. You know, there's just gaps, and I don't even what line is what. Very inconsistent time getting in bed. A lot of sleeping in, staying in bed. A lot of it's completely dysregulated. So much stress built up around the ability, the confidence to sleep. This person wasn't even taking sleep medication. That just built up so much stress around it. And so this is actually really remarkable. So this is late August. This is a number of years ago, but late August, and 2 weeks later, this is what we got to. So again, not perfect. What is perfect in life? But again, I would take this any day over that. Yeah, right? Pretty consistent going to sleep 1:30, still exercising, that's great. Some waking up in the evening, but it's for much shorter periods of time than this, right? Building up confidence in the ability to initiate and maintain sleep, and they're doing a pretty good job waking up at the same time, yeah? So just to illustrate kind of what we're talking about here and what we do. Long story short, so the Yerkes-Dodson law is a social psych phenomenon, which basically says that there is an optimal amount of arousal or sort of stress or expectation that allows us to perform or do anything at an optimal level. So anyone here basketball fan? Yeah, you know, hard to be a Laker fan this year, but you know, we had high expectations for LeBron. So if LeBron James is, he's trying to do a performance of shooting a free throw and making it successfully, we want his performance to be optimal, right? If he's sort of like, you know, it doesn't matter, we're not going to make the playoffs, so you know, whatever, throw it up there. His level of arousal is pretty low. His preparation is kind of like, I don't really care. That's not good. That's not going to help him perform at his best. At the same time, if it's too high, I better make this free throw or else, you know, someone's going to drop my sponsorship or, you know, I'm going to get traded, right? That's also, he can psych himself out. Also not going to be conducive to an optimal performance. We want it right in the middle, right? Where it's sort of like, all right, I'm prepared, trust my training and my conditioning. I'm concentrated, but I'm not like too fixated on the result. And the problem with people with insomnia is the tendency is to be way, way on the right side. I need to sleep or else something bad's going to happen. I'm going to have a stroke. I'm going to have Alzheimer's disease. And again, I'm not saying that that's not a possibility if that happens chronically, but sometimes we've got to do this piece temporarily to get back to a place of building confidence of sleep, in sleep, improving wellness, maybe even getting off medications. Heaven forbid, that'd be great. Just feeling a renewed sense of mastery over this basic and very vital thing that we all need to do. And that even worms do, as I mentioned earlier, right? Last thing I'll say, so safety behaviors, and this is again where insomnia can be similar to anxiety or OCD. The tendency is when we're anxious about something is to either want to avoid it, get rid of it because it's uncomfortable, or find a quick fix. And that actually tends to not work too well, right? So, I didn't sleep last night, so I won't commit to a lot of things, or I'll cancel things last minute, I'll cancel social obligations. I'm trying to fall asleep, so I'll try not to think about all the things I'm worried about, or try not to worry about sleeping. But it's sort of, you know, that just doesn't work. You know, if I asked everyone for the next 2 minutes to not think about a purple elephant with 3 eyeballs, you couldn't do it. Don't think about a purple elephant. Don't think about, you're thinking about it, right? Thought suppression does not work, right? We have to actually learn to tolerate those thoughts, or even better, minimize the time in which we might be dealing with those thoughts, especially in bed. Like I said earlier, I slept okay, but you know, I'm just going to take a sleeping pill. That's a safe behavior because it's a quick fix. But it doesn't improve our confidence in our most natural and innate ability to do this. Essentially, any attempt to reduce the unpleasant thoughts and feelings associated with insomnia can be problematic, and we've got to educate people about this because sometimes, you know, very bright people, we might have an intuition about these things, but kind of just need to be told from someone who kind of does this more frequently, and that helps. So, anyways, that's about all I have to say. This is some contact info. If you have other questions or feedback, I would welcome that. This is our practice website at the top. I do a little podcast as a side project related to all things mental health and therapy. We actually haven't done one on sleep yet, but at some point maybe we will. That's my email address. So, yeah, welcome any questions or comments in the back.
Could you comment on our medical residents who seem to have to work 24 hours straight?
Yeah, that's kind of a problem, isn't it? Do we want people?
If you can hear, it's fine.
Oh, if I can hear. Okay, all right, sure.
What is happening to the patients under their care because they're not doing what you've been telling us here for the last hour?
We could probably fill in the gaps at this point if we haven't already. Or the question is the concern regarding medical residents and their inhumanely long shifts of hours and training and the patients under their care. The system needs to change. I'd put it that way. Because again, it's not just, and by the way, rates of mental health issues, depression, anxiety, substance abuse, and suicide among medical students and residents have increased. Not to mention the people that they're responsible for. And that's built into the code of ethics for physicians, right? Is, we're here to do no harm. We're here to help. And if we're not in a position to do that for ourselves, how can we really be of service to someone else who needs our training and experience? Great question. Any others? Yes, sir.
What are the benefits, if any, of melatonin for sleeping?
The question was, what are the benefits of melatonin, if any, as a sleep aid? There are benefits. We all have different sensitivities to medications, hormones and vitamins, etc. Melatonin is the hormone that influences the circadian rhythm I mentioned earlier, which is sort of the timing of when we start to feel sleepy. It's not what initiates sleep, but it's the feeling of fatigue, if you will. For people getting over jet lag, melatonin can kind of, it pulls up that feeling of sleepiness. I don't know that there are, to my knowledge, long-term side effects. A lot of people find it really helpful if they're trying to, like I said, deal with that shifted circadian rhythm. For us as older adults, that we may not, we want to kind of push things back a little bit, right? If insomnia is a problem for us. So, another question here? Yeah.
Let's see. I'm sleep deprived all the time, probably get 5 to 6 hours of sleep a night. And my question is there different symptomology between a person who is an insomniac and only gets 5.5 hours of sleep versus somebody who is making the decision to be sleep deprived and only gets 5 hours?
Good question. So again, the question, just in case in the back, was, is there a difference in presentation or symptomology, if you will, between someone who is sort of voluntarily sleep deprived versus someone who is trying to sleep but not able to get adequate sleep, aka insomnia, right? I would say symptom-wise, it may not necessarily be different. However, upon inception, the whole thought process behind it is different, right? Because if I'm someone who, just for whatever reason, obligations that I have to others, work, etc., or am avoiding something by being really busy and not sleeping enough, I may actually be living in a state of, well, hey, I'm keeping busy. I'm living a full life, carpe diem. I'm making good use of my time. In fact, that's something that I think societally, so I'm not saying about you, but for a lot of us, we have to combat is this whole idea is the sort of adulation of the person who is super productive and is, works until 9 p.m. and then is texting at 11, answering emails at 4 a.m., right? I think that's a problem, right? So symptom-wise, it may not necessarily look that different, but the mentality of someone with voluntary, if you will, sleep deprivation may be different. They may not necessarily feel anxious about their ability to sleep because they know once they give themselves the opportunity, they can do it. They're voluntarily doing it, they're choosing it. They may have very good reasons on paper to choose that. So they may not be, if you will, conflicted about it because they feel like they're making good use of their time. The person with insomnia feels like, I am wasting time sitting here tossing and turning in the dark while everyone else is doing the thing that I want to be doing. That's a terrible place to be. So I think that's how I'd make the distinction. In the back, yeah.
Yes, do sleep medications like Ambien, Lunesta, things like that, do they affect the actual quality of sleep? And then additionally, do they create an actual physical addiction of any kind, or is it more psychological?
Say that last part again.
And do they create any sort of a physical addiction, or is it more of a psychological one?
Both and. To the last question, the question was, do sleep medications such as Ambien and Lunesta build up physiological as well as psychological dependence? Yeah. And then the first question was, do they affect the quality of sleep? Right. Okay. Good questions. So yes, because a lot of people will describe, I took Ambien or less or whatever, and it helped me fall asleep, and maybe it helped me stay asleep, but I wake up and I don't necessarily feel more well rested, right? Because it's messing with the natural flow of all the hormones that we want to be going on during our sleep. It's an artificial suppressant, inherently. It's an artificial suppressant. So it on paper looks like it's helping us. And again, by the way, I'm not anti-medication. I should make that clear. If it's helps someone in a pinch, there's a place for it, absolutely. I'm just offering an alternative perspective. It doesn't have to be either or, it can be both and. Similarly is, yes, absolutely, the placebo effect is a known and well-researched and established phenomenon, that just the idea, as I mentioned earlier, I need my Ativan, otherwise I can't be able to sleep, is very powerful. But yes, of course, these drugs do things to us. And so there's what we call rebound insomnia, where the person who says, I've been taking this thing to help me sleep, and I'm going to not take it. And then that's actually going to be the hardest time for them. And if they're thinking quickly things are going to get better, we got to adjust that expectation, right? Because they might actually have a harder time initiating sleep initially because their body is dependent on the substance, right? So hope I answered both of them. Oh, by the way, yes, some medications, people drink, people use cannabis to help sleep, and all sorts of cannabis-related projects, suppress REM. A lot of them suppress REM, right? So again, we're getting sleep, we're not awake, but are we getting the benefits of really all that good stuff we talked about, and especially on the back end? Yeah, another one in the back, sorry.
You mentioned earlier about sleep apnea. Do you have a comment about that?
Sleep apnea, right. So some of us may know about this, right? We're more at risk for sleep apnea if we are older men with a higher end of the body mass index or thicker neck circumference, right? Sleep apnea can be a serious issue because it's irregularities in our breathing during our sleep, which can affect the amount of oxygen we get to our brain, right? And so what we tell people is, that should always be at least being treated and somewhat under control with a CPAP, which is the gold standard device for sleep apnea, before we engage with CBT-I. So, and a lot of people will have both, a lot of people don't. A lot of people have only sleep apnea, not insomnia. They acclimate to it, it's helpful, great. In fact, I've seen it work wonders, which is great. Some people will have both, where it's okay, great, I'm treating my sleep apnea and with the CPAP, but it can't, it can feel like a cumbersome, it's uncomfortable device, it feels smothering, you have to listen to it, you got to clean it. That's frustrating, and that can sort of contribute if there's already an anxiety about sleep built up. So, but we want that to be treated first. Yeah.
Does that develop or hinder REM, or does that involve the quality of sleep that we have if we are apneic and we're not being treated?
I would think so. I don't know I know just enough about science to inform what I do and do some damage, which I've inflicted upon you folks today. But I would think that that would affect REM. This is a key element of sleep. Yes, sir.
Can you suggest some techniques that people might use to adjust their schedule once they get on an airplane and fly 10 or 12 time zones away?
Yeah, that's a tough one. Melatonin is sort of a quick fix tool go-to. But how do we naturally sort of build up the melatonin is also with our exposure to sunlight, right? So actually one of the recommendations, this is semi-related, is again for older adults, if our circadian rhythm is starting to inch forward, is to have sunlight exposure in the early mid-afternoon, because that sort of, and actually not limit it, but mitigate it a little bit more in the mornings. Like something we can get up, we go for a walk, was we want people, sometimes we'll have people wear sunglasses in the morning to limit the amount of sunlight that's creating that melatonin in the morning, and we want to shift that back into the afternoon a little bit. So, depending on which way, if you're flying west, east, there may be some component of that to be sort of manipulated, if you will, to help adjust a little faster. Yeah. Yes, ma'am.
I have very, very active dreams, like I'm wrestling all night and working, and I wake up exhausted and I'm tired throughout the day.
Yes.
And so, is there anything that can be done about that?
Can I repeat the question? The question was about having very active dreams and how that, if you wake up exhausted from your dreams, that affects the rest of your day. And again, I don't want to get too personal unnecessarily, but if they're distressing dreams or repetitive themes, and I'm not going to get into psychoanalysis and dream interpretation and stuff, but long story short, if it's more sort of on the what we would call a unpleasant nightmare spectrum, we could take a look at that, and we want to. Sometimes we will rescript what happens in someone's dreams, if you will, where we rehearse an alternative version that we can control in a waking state, and we repeat that, we tell it, we listen to it over and over again, and that in some way, right, it gets consolidated in our brain and competes with the stressful version of the dream that we may be having, or even the variations or the themes of it that come up in our sleep. So that'd be one piece from that perspective, is the rescripting element. I don't want to say too much without knowing other history, but yeah. So. Yes?
I'm a wonderful sleeper, but
Congratulations, yes.
on times that I'm not able to sleep, I seem to dredge up not what's going to happen tomorrow or any kind of commitments that I have. I dredge up issues from the past, and then I wake up and I think, well, was I dreaming, or was it the first stage of sleep, or did I sit here for 45 minutes and think about what I did 40 years ago? I mean, why am I thinking about things in the far distant past?
Right. I'm a psychologist. You said something about issues in the past. We don't really. Joking. Yeah, if it's not causing a problem for you, if it's not impairing your daytime functioning, I wouldn't be too worried about it. Sometimes it actually, I'm not sure how you'd feel about it, but depending on what it is, can actually be sometimes interesting things can come up when we're in that sort of gray area where it's like, I might not have thought about that if I was wide awake, and I might not have been aware of it if I was totally asleep, but like there's sort of this weird crossover zone of kind of creativity and associations, right? And sometimes if we can recall those things, or if you're awake enough to write it down, it might just be interesting to jot down for introspection purposes. But again, if it's not a problem, sounds like you're historically otherwise a pretty good sleeper, then I wouldn't worry about it too much. Yeah, Barbara.
What about things like Tylenol PM?
Yeah, Tylenol PM. The question is, what about Tylenol PM? Someone took a Unisom on that other sheet. I mean, again, similarly, as most people that we consult is if we don't have to take something, we'd rather not, because we can build up dependence to it. If someone's actually taking it because they're sick, it's like, please, take it as recommended over the counter. I probably wouldn't encourage someone, especially if there's a propensity or a tendency towards anxiety or insomnia, to rely on something like that, right? Because that's what we call the safe behavior, right? So it works. It might work, but does that mean it's most helpful for us in the long run? Yeah. So, anyways, I want to respect everyone's time. I could take one or more unless we want to. I'm happy to stick around if people have other questions. Then. So, yeah. My pleasure. Yeah.